National disease registries are powerful tools that can greatly assist in improving the quality of healthcare. Medical analysts use these centralized disease-specific databases to study treatments and evaluate those that work best. Data in national disease registries, that's NDRs, are collected from very large population groups that span a broad range of ages, races, gender, and other characteristics. The treatments that develop based on such large data groups are firmly rooted in scientific evidence and tailored to specific patients. When doctors combine their medical training, experience, and judgment with evidence-based treatments, patients receive the highest quality of care. In part 3 of this documentary, we will examine how a nationwide EMR system enables the establishment of a national disease registry. We will see how NDRs can contribute to rapid accumulation of significant sample sizes to aid research on new medical treatments, prompt tracking and evaluation of new medical treatments, efficient monitoring and assessment of infectious diseases that have the potential to become epidemic and pandemic outbreaks, quicker diagnoses and interventions of rare disease. In addition, we will explore how de-identified data, the current standard applied to information sharing, is relatively ineffective in determining the best medical treatments, how biased databases do not represent the entire population, and how they compromise the efficacy of medical research.
We've been doing that in medicine for years. We have been collecting as large a population of similar patients as we can to then make informed decisions based on varying clinical options and varying clinical outcomes. I think what EMR brings to the table is the ability to analyze much larger databases. To take a nation of data, a nationwide population of data, to standardize it in a way such that treatments can be grouped in similar ways and outcomes can be grouped in similar ways, empowers you in ways that are almost inconceivable in the past.
And having access to a symptom registry or even a disease database where you can see what other groups have tried in such a rare condition, a rare, almost universally fatal condition, may help to allow for that treatment to occur faster.
One of the challenges that we have in research is a limited pool of patients. Breast cancer is a perfect example. Much of the research on breast cancer is actually coming out of the academic centers, which, but for a few, are locating in very urban areas, and as such, draw upon the demographics of that type of patient. It's hard and almost impossible to take a more broad sweep of the nature of the cancer from a suburban area. Many of those suburban hospitals don't participate. If we create a national registry, researchers can draw that information and I think expand the body of knowledge. For me, the next horizon is oncology and cancer.
Today, no existing database reflects the full spectrum of American disease treatments. This worthy goal can only be achieved when the following steps are taken. Americans become more active in adjusting privacy laws to enable the sharing of medical information. The current provisions for a national EMR system are expanded to include developing a national disease registry. I hope that we will increasingly move forward with such important actions over the next several years. I'm Dr. Anthony Messina. Thank you for listening.